But we cover everything.
Gentile.
I normally get Gentile quite a lot as well.
Yeah, Gentile. I didn't even know. All right. I'm joined by Natalie, who is from Children's Nursing Queensland. And so a little bit about Natalie. After initially completing a Bachelor of Social Science, Natalie's passion for social justice closely aligned with her desire to help patients and families receive appropriate and compassionate health care. She commenced her nursing career in 2015, and she's worked exclusively in pediatrics. She's a registered stomal therapist and has extensive experience with surgical, stomal, urological, and burns patients. And now, as a clinical nurse for Children's Nursing Queensland, she provides a warm and empathetic approach to her care and focuses on providing family-centered care. For those of you who don't know, Natalie's in partnership and business with her friend Lisa, and they together run Children's Nursing Queensland. And whilst they are Queensland based, they are available for telehealth consultations as well. And really what Natalie's going to do tonight is talk to you all about the type of things that are covered in her world of nursing, because there may be some things that you're not thinking of, and really how to get the most out of that, and how to best incorporate those things, if they're applicable to your child, into your NDIS plan or into your plans full stop. So as I mentioned, yeah, Lisa and Natalie's business is based in Queensland, but they're available via telehealth. And we will definitely send through all the details for how you can get into contact with both Lisa and Natalie in the coming day. I will send an email to everyone who is registered for this event, and you will get a link to the recording of tonight's event. So don't worry about having to furiously write stuff down. We will send you a link to this so you can watch it back if you need to, but we'll also send you all the contact details. So if you do want to reach out to book an appointment with these guys, or to ask a question that you may not necessarily want to ask in this public forum, please feel free to do so. All right, so without further ado, I will pass over to Natalie, and we will get started. And just a reminder that if you do have a question, to pop it into the chat or hold on to it, and we'll get to the Q&A at the end of the session. Thank you.
Thanks for introducing me, Paul. You know, I hear all of these wonderful introductions you're doing for all of the other kind of NAPA nights coming up. And I know Mel is just so fantastic to listen to. So I would really strongly encourage everybody to go and listen to Mel talk. And I'm sure your new consultant's going to be amazing too, because the mother of a toddler, sleep is always an issue that I think we could learn a little bit more about. Thank you for introducing me. Like Paul said, I'm a nurse, and I'm also a stomal therapist, and I'm one half of the nursing directors from Children's Nursing Queensland. My colleague Lisa and I, who I think Lisa might be stalking around somewhere in the audience there as well, so feel free to throw some questions her way. We met working at the Children's Hospital here in Queensland, and we were working there for a number of years in different roles. So my kind of background was more in surgical and burns and really high acuity patients. And Lisa's was sort of the polar opposite of that. And she was mainly supporting people in more of that rehab, spinal disability and spinal cord injury space. And we met working in the stomal therapy department. So we'll talk a little bit about what stomal therapists do. But essentially, when we were working together, we just sort of identified that a lot of the families of children with really complex needs weren't able to access specialist nurses in the community for lots of different reasons. One was that they didn't have the kind of NDIS budget to support them to access those services. One was that a lot of the specialist nurses didn't exist in that kind of community space, whether that be from families being regional or more remote, or whether there just wasn't a lot of specialists out there. And also people didn't really know that it was an option for a lot of them. So we figured that somebody should sort of do something to meet that demand. And that's when we launched Children's Nursing Queensland. So we have been out there doing our thing since 2022, towards the end of the year. And we love it. We love being able to support families in the community. And we have gone from just being Lisa and myself to having a wonderful little team of nurses and stomal therapists as part of our team. And we're continuing to always look at ways that we can kind of grow and develop our service and help families to really make the most out of their NDIS plans to make sure that they can keep their child out of the hospital system wherever possible, and to kind of reduce that demand on the hospital setting as well. So it's a little bit about who we are as Children's Nursing Queensland. Like Paul said, we are based in Queensland. There's obviously children in the name, Children's Nursing Queensland, but we do have some adults that we support as well, where we might be the most appropriate support. And we also do consults nationwide for telehealth. We do have one nurse as well, and stomal therapist, who is based in Melbourne, but just with limited availability. So we may have capacity to see clients down there as well, just depending on the kind of time frame if you're needing a face-to-face review. So a little bit about what we do as stomal therapists. So it is clearly not the most glamorous nursing position, but we absolutely love our field. We like to joke that as stomal therapist, it's a like pee, poo and pus sort of approach. Really glamorous, really. So we do a lot of work, obviously, with stomas. So stomas are a surgically made hole that goes somewhere into the body. So there's stomas everywhere in the body that surgeons can make. Obviously, we're more familiar with things like colostomies or ileostomies, which are surgically made holes in the abdomen to drain feces out of the colon or the ileum. But there's lots of different types. There's bowel stomas like maces and chates that are designed slightly different to the more traditional bowel stomas. There's things like urine stomas as well. And there's things like feeding stomas or stomas that drain saliva or airway stomas. So lots and lots of different types. Most of the ones we deal with are pee, poo and feeding tubes as well. So enteral feeding stomas. In kind of line with that pee and poo theme, we also do a lot of work with things like continence, specifically for children with complex needs or disabilities. So that's a big area of our kind of service profile that we offer support for, and a lot of the reasons why families of NAPA engage our assistance too. And that might be around things like catheterization, it might be around things like transanal irrigation, or trying to help a child achieve continence who might have a medical condition or a disability like ASD or ADHD, and the kind of challenges that come along with that. So that's another big area that we support with, is that complex continence. We do lots around the pus part of it as well. So things like complex wound management and pressure injury assessment and management as well. And we can do that really well in the community, which I think is a really rewarding part of our job, because it keeps those kids who aren't sick enough to be in hospital, out of hospital in the home environment. And that's a really positive part of our service, I think. So that's sort of what we do in that stomal therapy realm. Our service also does a lot of support with enteral feeding stomas. So feeding stomas like jejunostomies, gastrostomies, PEGs, gastrojejunostomies. And with that, all of the things that kind of come along with that. So measuring stoma tracts, managing skin breakdown, recommendations or advice about which sort of feed-in tube that child or person may need as well, and the sort of assessments that go along with that. So writing nursing reports and things. It is important to note that stomal therapists are a dying breed. In Australia, as far as paediatric stomal therapists, there is 17 of us, 3 of which work with Children's Nursing Queensland, Lisa, myself and Amy. There's really also not a great deal of adult stomal therapists either. So we know that there's a shortage of stomal therapists, but the demand continues to be there and will continue to be there. So we're really pleased to be able to offer that service out and about away from the hospital system. So that's what stomal therapists do. As nurses, some of the cares that we do are a little bit different to stomal therapy, or a little bit on top of that as well. So I've touched on some of them already. We do a lot of assessments with Children's Nursing Queensland, and it's probably one of the main reasons that people choose to engage our service. So an assessment is needed for lots of different reasons. So sometimes we will have families who want to know about some strategies and ways that they can improve their child's continence, or improve their tube feed-in regime or their tube feed-in stoma, or strategies to support with kind of pressure injury prevention and management. And so it's a great part of the assessments. We can definitely do that and write that within our report. But the kind of flip side of our assessments is that they provide a really good justification to the NDIS, linking how that child's disability directly relates to their sort of nursing requirements. And I think having that written down and having those dots really close together for the NDIS to understand that's really important, particularly with continence. And so as part of our assessments, we include recommendations, we include references, we include all of the quotes that families might need from medical supply companies or other places that kind of, again, just add that kind of weight to that assessment and really clearly identify what those needs are and the justifications behind it. As nurses, we also do a lot of work around tube feed-in support. So not just, I guess, feed-in stomas, but also things like nasogastric feeds as well. And that looks very different for every person. A lot of the time it's around product selection and skin management, particularly leaky tubes. For anybody who's got a tube feed-in one at home, we know that the leaking tubes can be a really frustrating and difficult thing to manage for a lot of parents, particularly if you don't have that kind of support at your local hospital. Care plans is a big thing that we support a lot of people with as well. All of our children that we see will go somewhere at some point, whether that's early learning centres, schools, supported living environments, day centres, that sort of thing. And so care plans are just a really good way to really clearly document how to safely care for your child and their specific needs. You know, anyone can go and print off, I guess, something from the internet about how to care for a child with a gastrostomy or how to care for a child with a colostomy, but making sure that those needs are really specific to your child is a really important part of their care, and it helps make sure everybody's on the same page to deliver a really safe and targeted care plan for your child. Education is a very big component of what we do. So prior to us sort of going into this education space, we had a lot of families telling us that they didn't think they could send their child to daycare because their child had a stoma or needed certain things like catheterization done, or just had complex needs and they weren't sure that daycare would be able to support with that. And that kind of existed all the way from early learning centres all the way through schooling as well. And so most places are really grateful when we come along. We say we're happy to support all of the parties for that child to attend safely. Where possible, we try and do that in person. Sometimes with our more regional areas, we might not have capacity to, but it's lovely for us to go in and we provide kind of theoretical information. We show them different devices and we talk about not just the care of that particular child and their needs, but we talk about things like the basic anatomy of the human body and why, you know, we have to look after a feeding tube in a certain way, for example, the surgical reasons behind it, and just kind of try and add in the why as well as the how. And I think that's a really important part of making all of the parties feel really comfortable and very confident in managing that child. And I think it's a really important piece as well to have everybody on the same page. You know, we talk to a lot of families and I think there's always a lot of anxiety about children going into places like early learning centres if you've been their primary carer and they have complex needs. And so making sure that all of the parties are on the same page just starts off a really lovely open communication and open dialogue between all the different parties. Advocacy and kind of liaison with other healthcare services is really important. I know Lisa's in the background there and probably not in her head, but, you know, we quite often get calls from families saying that they may be having challenges accessing other services, or they may be having difficulties finding appropriate clinicians that can support them or appropriate services. And so we spend a lot of time talking with other clinicians and other services and trying to learn about the different kind of programs and different services and different supports that are available on offer. Doesn't mean that we necessarily promote one over the other, but it just allows us to sort of engage with families and give them options about the other services that are out there. And we do a lot of telehealth. So, you know, I think COVID, the one thing that it taught us is that we can do healthcare really differently. We don't always have to have every single person come into, you know, miss school and miss work, battle their way into the inner city hospitals, pay for parking, find a car park, and wait around for hours to be seen. You know, we can do healthcare really differently. And particularly for people who have children and children with complex needs, you know, packing everything up and getting in the car is a real challenge a lot of the time. And telehealth's great. It lets us talk to people in their own environment in a way that is, you know, less intrusive. And I think that's a really powerful tool as well as clinicians, because it kind of gives some of that power back to families too. So telehealth's a massive part of what we do. Sometimes we would prefer to see people, you know, face to face. It's just not always possible in this wonderful big country of ours to get everywhere that we can. But as time goes on, we're managing to service more areas, and we try and do regional visits and outreach whenever we can. Our next trip is WEPA, so watch this space. So I think it's really important to know the kind of services that you can get from a clinician in the community, the kind of services you can get from a clinician in a hospital setting, and when you might need to engage one or both of those parties. So I think, from my opinion, that community nurse specialists are the way forward. You know, we've had OTs and physios and all of the other kind of allied health teams offering community services for a long time. And nurses do to a degree, but it's definitely kind of been on the outer side of what's expected. And so now I think as time goes on, we're starting to see the value in having some of these specialists offer in-home or community care, particularly around things that are non-acute. So if your child's not unwell, it doesn't make a lot of sense to take them into a hospital where they're at risk of getting something that might be in that hospital precinct. So, you know, we get a lot of children who just need their tube changed, whether that's a feed-in tube or a chate. And for families, having to go into a hospital setting can be dangerous because they don't want them to get caught with something else. And they may have medical trauma associated with it. And then all of those other issues we spoke about earlier with things like missing school and work. So if it's not acute and we can plan for things, we absolutely will do that wherever possible. And I think that kind of capacity building and encouraging families where possible as well to kind of work with us to solve issues and troubleshoot is really important. Product trials is a really big one. So say, for example, something like feed-in tubes. I can think off the top of my head of at least 6 different feed-in tubes on the market. And so sometimes you just want to know what's out there. You want to have a feel of things. You want somebody to talk to you about, you know, the benefits and the, you know, the disadvantages perhaps of certain products. And I think that's a really important thing that your community nurse should be able to help you with. The other thing is continence aids is a big one too, particularly as children sort of transition out of grocery store continence aids or pull-ups. Being able to engage with a specialist who can provide some samples for you and then also kind of talk you through those samples is really key. Accessibility is a big one. I would say the majority of our clients live in a metropolitan area, but definitely a large portion still live outside of metropolitan area, whether that's regional or remote. And everyone should have the same access to healthcare. It's just not always that easy. So being able to offer a service where we can talk to people to begin with and sort of triage their concerns appropriately, I think is a really big part of community nursing specialists. The other thing is, of course, those lovely non-clinical things. So assessments, reports, and non-clinical supports. Again, if you're not sick, we don't want you to have to go to hospital. And so often you'll find if you do go to hospital that they're not able to offer those sorts of services in there either. Just because they're so time poor with the kind of big demands that are placed on them within that hospital setting. So for things like high intensity skill descriptors for support workers, we know that all of your support workers, school staff, day programs, anybody who is supporting your children, if they've got complex needs to be trained appropriately in how to manage those needs. And so that's an annual requirement for a lot of those specific things. So think about things like bowel management programs or peg feeding, that sort of thing. So that's often a really good way to access nursing supports in the community. When we do want you to see a hospital nursing service or a medical professional is if your child is acutely unwell. So things like fevers, vomiting, pain, those sorts of things, we would always recommend that you seek a medical review, because unfortunately Lisa and I and our other nurses don't come with x-ray vision. We're not able to diagnose, so make sure that you are accessing that healthcare when you need to, if they are unwell, is really important. And at the request of a treating team. So sometimes your child's clinicians may want you to see a community nurse, or sometimes they may prefer you to see a hospital nurse. And that's often really specific to your child and their specific needs. And we would always encourage you to follow their lead, because they know your child really well if they've been part of their team for a long time. The one thing I would say is it's really lovely if you can chat with your child's treating team ahead of time. So before issues arise, we have a lot of families that register with our service for that exact reason. They, especially after NAPA nights, they might get in touch with us and say, they've got a child that has a particular condition and they're concerned that they may need our assistance, but they just don't need us quite yet. And so they'll have a chat with their treating team, make sure it's appropriate to engage us, register with us. And then that way, if they need that support, then we're just a phone call away, and we can normally get them in within probably 1 to 2 business days as they need us. And if they need us, which hopefully it would be lovely if they didn't need us. Finding the right service for you. So we are one of many nurses in the community. We are not one of many paediatric stomal therapists. There's definitely not any others that I'm aware of. But when you're looking at the sort of nursing services to engage with your child and your family, you really need to, I guess, think about the sorts of supports that you're after and make sure that they are the right supports for you. So just probably some questions to think about asking of your nursing supports is, what's their qualifications? Obviously, RNs and ENs are a little bit different in their kind of in their undergraduate training that they have, but nurses themselves also continue to learn. So nursing is really a lifelong love of learning that you have to have, and that's mandated into our registration. We continue to learn and do professional development as we transition through our nursing careers. Some nurses, as part of that, will do extra qualifications. So if you're looking at somebody who's into continence, you would hope that they would have some other kind of training under their belt that really helps them have an understanding of that specific need. So obviously there's the piece of paper, and then there's the other arm of that is that kind of specific experience. So make sure you ask, what's your particular experience with this condition or this disability? And they should be able to explain it to you pretty well. And if they can't, I would probably have a little bit of a think about whether or not they know the complexities of your child well enough to be able to provide the appropriate supports that are needed. So hands-on experience is a really big one there. Pediatric experience, this is probably one of my big bugbears. Children are not just little adults. And we know that, the management of them, the kind of conditions and disabilities that we see, the sorts of issues that may arise, the goals that we have for children, the treatments that we have available, they're really different to adults, particularly around things like continence. And so if you get an adult nurse who goes, I can do kids, they're just little kids, little adults, or, I haven't done them before, but I'm sure they're much the same. That would be a big alarm bell for me, to make sure that you're finding someone who has that really specific pediatric experience to help you with your child. The right fit's another one. You have to gel with that nurse, and you have to trust them and know that they're the right fit for you. And that's going to be something that only you as parents are really going to be able to decide for yourself. So make sure they're the right fit for you. Ask those questions and see the kind of responses that you get, and see how you gel, and make sure that you've got that good trust build up and that professional relationship there where they can offer you a service and you feel as though they're going to be able to give you what you need from that service. The other thing is funding options. I would say 90% of people who come to us don't have any form of nursing built into their NDIS plan. And so that can kind of put a lot of families off. They think they don't have that, so they can't access a continence nurse, or they can't access a nurse to help review their gastrostomy or to provide education to their early learning centre. So there's lots of ways around that. I think probably the first is, until you really get assessments, you'll probably find that you don't actually have a lot of supports built into the plan because they haven't been addressed by a nurse. They've been addressed by potentially a physiotherapist or an OT or something like that, looking at functional capacity and not really focusing on the nursing needs of your child. So sometimes using our service and drawing on capacity building or core funding is useful because we can write that report and help justify the need for nursing supports within that plan, even if we're not the nursing service that may be delivering that nursing care throughout the year ahead. So it's often worth thinking about that. Some of our kids also don't have NDIS, which is, it can be a little bit trickier to manage. And so there's sometimes other funding avenues that we can look at, things like CAPS, which is the Continence AIDS Payment Scheme. We can help families apply for that, which gives you a very small sum of money, but a sum of money to help go towards continence supplies and services throughout the year, those sorts of things. So if you're not sure about the kind of funding options and if you've got them available, the best thing you can do is engage with that nursing service, whether it's us or another nursing service, ask them about the sort of fees, ask them what the expected outcome of their service would be. Obviously, we can never guarantee things, but you'd like to know, what kind of goals would come out of that. And then see if you don't have NDIS, what kind of other services they may offer. And sometimes speaking with your plan manager can be useful there as well. So guys, I have kept this purposely sort of brief because I think we've done a few of these NAPA nights now. We often talk about, kind of practical things like continence management for children with disabilities or complex needs or tube feeding. And so this is a bit of a new topic for us. And I think it's really nice to hear from parents. We learn a lot coming in and speaking with families as well about the sorts of questions or concerns they may have. But I welcome anybody who's got questions about how our service works, how to engage nurses, how to make the most out of nurses within your plan, specific nurse-related questions. I'm all ears. I don't think we've got any questions in the chat, which is fine. Did anybody have any questions at all that we're perhaps able to answer for you today?
We usually have to give them a little bit of time to warm up, but I'll kick you off and get you started, Natalie. I remember one of the previous things we talked about was, just how big continence can be, and I mean, as a NDIS line item, right? And what sort of things should our families be thinking about? Like, it's not just perhaps the nappies or whatever it may be. Like, what are the things that we need to, and what sort of process do you follow when meeting someone to do a continence assessment, for example, to help them get to the point where they can then arrive at the amount that they need to be putting into the NDIS report or review or request?
Yeah, continence is a big one. I think because there's a lot of myths around continence and the NDIS. So we hear a lot from families that, I'd love to get your services on board, but my child is, I don't know, I've heard every number, 4, 5, 6, 7, 8, and NDIS won't fund consumables or continence supplies because it's considered a standard parental responsibility at that age. And the answer is actually for 99% of the kids that we see, continence is related to their disability. And so if continence is or incontinence is directly related to your child's disability, you can get continence funded. It's up to us as clinicians to basically justify why and provide evidence for why the disability is related to that incontinence. And so, like you said, Paul, a lot of people we speak to say, I'm already funded for my pull-ups or my tap style aids, and that's all we use. But actually, when you think about all of the little incidentals that you might buy throughout the year, so things like barrier wipes, regular wipes, blueies or pinkies or Kylies, depending on what you want to call them, continence linen, continence swimwear, even sometimes products like aperients, like Movicol or Osmolax, if they're part of a bowel management regime, we can get funded. So I always think it's worth considering having a proper nursing assessment, particularly for something like continence. The other thing is, continence is so broad and there's lots of different specialties that offer continence assessments. I know that Kelly is a fantastic physio out of Sydney NAPA, and we've done a talk with Kelly before. sometimes the kind of continence specialist that you might have can vary depending on your child's clinical need. So there's OTs, there's physios, and there's nurses, and they each offer similar services, but also some kind of unique things that are individual to their particular profile. So a nursing assessment, I always say, is a good place to start when you're getting continence assessments, to identify any kind of potential medical red flags. Because it's a little bit trickier to do that if you're not trained in that field with something like physiotherapy or OT. They don't quite have that understanding of the pathophysiology and the kind of disease processes associated with a lot of urological conditions. So I think having a nurse assessment is a great place to start. And often we find physiotherapists and occupational therapists are really great at also building up that kind of functional capacity and the muscles needed at the other side of that too. So I think it's worth always having that chat to make sure that, to make sure continence is included. Yeah,
Fantastic.
Good question, Paul.
That's all right. That's all right. And I guess the same question kind of in regards to, if your child has a stoma or whatever it may be, like, I hear different parents at NAPA tell me that, well, the tubes and the syringes and all those needs, well, they've been told that that's part of feeding the child. And like, so you wouldn't hit the NDIS up for a knife and fork, for example. So why do we feel entitled to hit them up for things like, syringes or whatever? What's your kind of position on the feeding side of things?
I think that's very interesting because we do hit them up for knives and forks. If you've got a child who has adaptive feeding tools, absolutely they might need adaptive cutlery. Yeah. It's interesting to me that we could have a room full of children with the same diagnoses and the same conditions and they'll have their plans done up and they'll go to their planners and they probably wouldn't all be told the same amount of information, but I very much doubt they were funded, even probably remotely similar. I think feeding needs specifically, if your child has a feeding tube, if it's related to their disability, you should be funded for those kind of consumables that are associated with it. There's always going to be this little grey area where we go, is it medical or is it disability? And sometimes it's one and sometimes it's the other, and sometimes it's not really clear. It's a mixture of the two. And so we have to use our clinical judgment a lot as clinicians when we write our reports and when we're looking into those reasons to make sure that things are considered reasonable and necessary and value for money and directly related to that disability. I would say in our time doing this, I find that we very rarely would not make that link. I think most of the time we can see a clear connection between disability and the reason a child has a feeding tube, or the reason that a child with ASD may have some issues with toileting. It's just making sure that we can document that well enough for the NDIS to understand. And we welcome feedback from families. We do a lot of these assessments and we hear from a lot of families and we talk to a lot of families. So sometimes we'll have a family kind of come back to us and say they didn't get as much funded as they would like, and we can look at why that might be the case. And so going back and reflecting on why things are maybe not approved is really useful for us to understand as clinicians if there's stuff that we can go wrong, but also just to understand the language that we need to use to get things over the line, so to speak.
Yeah. Great. And just a quick, my final one before I head to Marianne's question is, for your telehealth appointments, and when parents are wanting to have an initial conversation with you or an assessment, even whether it be continence or other, they don't necessarily have to have the child present. Is that correct?
Absolutely not. I think we rarely have to have the child there, particularly for assessments, because parents are the people that know their children really well. They're the great, history keepers of everything. So it's normally more of a history taking appointment. And the other thing, for a lot of our children, they may be nonverbal or they may have issues with their ability to communicate with us or desire to communicate with us about things like toileting, might be anxiety provoking. And so parents are definitely the people that we speak to first. We normally, for our big assessments, allow about an hour, sometimes 2 if your child's really complex, so that we can get a really good understanding of all aspects of your child's life. So mobility, communication, toileting, feeding, all of those sorts of things. And And absolutely, children do not want to be part of a very long, boring conversation with nurses. As they get older, we welcome it, especially if they feel like they want to be part of it. We of course welcome it, but they don't have to be there. No.
No worries. All right, guys. Just a reminder that we are getting towards the end of the presentation tonight. But if you do have questions, as I said when we kicked off, this is your opportunity. You've got an expert on the screen right now, and it's not me. It's Nat, so she'll be able to answer. Well, if she knows the answer, she'll be able to answer that tonight. But I'm going to fire one at you, Marianne. Nat. This one's from Marianne. She's got lots of questions, so I don't know if she's going to follow this up with more, but she's going to start with this one. She wanted to pick your brain, and she says that she has found Kenacomb. I don't know if I'm saying that right. Mm-hmm. Kenacomb is the most effective for G-tube granulation over the other go-to creams, and she doesn't do silver nitric. What's your recommendation for granulation? We use Prontosan when looking good.
I love all of your pronunciations of those, Paul, because you got them all right. Perfect. So hypergranulation is basically, for those if you're not aware, when you have a foreign body in, whether that's a tube or your earrings or whatever it may be, your body recognizes that and tries to heal over it, and it can't because there's a big tube in there. And so what ends up happening is you kind of have this proliferation and cell growth of all of these cells that ends up kind of forming this really bubbly kind of tissue that sits around a tube. And in and of itself, it's not an issue. But what ends up happening is, rather than having a nice kind of circle there where you've got a tube sticking through it, you can end up having these kind of, bulging parts of it, so you get more leaks. And leaks are bad because they can be quite painful to manage, and means we can lose medications and that sort of thing. So when we need to treat hypergranulation, which is not always, but when we need to, we normally try and start off really conservative with something like a salt soak. We use really salty water, and we wrap it around that tissue and leave it on for a short period of time, and that might be enough to keep it at bay. I would say it's not super successful unless that is very mild tissue. So our next step would be something like Kenacomb. So Kenacomb is a mild steroidal ointment. It's really effective, but the issue is that it's systemically absorbed within our system, so we can't use it for more than 7 days without it being absorbed by that child. So the other thing is you need a script for it, which is a little bit tricky sometimes. The other thing that we use is silver nitrate, which looks like a big long matchstick, and we apply it to that hypergranulation. It effectively cauterizes that skin. We are told that hypergranulation has no nerve endings and shouldn't cause any pain, but anecdotally, kids definitely seem to have varying experiences of having that tissue cauterized, and sometimes it can appear really painful. The Prontosan that Marianne mentioned is a fantastic wound soak. It's really good at keeping that area clean and getting rid of any kind of bacterial load that's on there, so that's fine and safe to use. But I would say managing hypergranulation, there's some new products out on the market that we're trialing at the moment, some that are specifically designed for stomas, and we're still sort of in the trialing phase of that. The product that we've specifically found has been really useful is called a tray seal. It's made by a particular brand called Zanzac, and it's I think I've got one in front of me here. It's a kind of one that is formulated with a specific chemical compound, and we don't know why, but it seems to have a really good impact on stoma hypergranulation tissue. So we've been trialing that a little bit. They are a stoma product. They're available from a lot of different medical supply companies, and they are a circular shape, or this one's a bit off center, and they're normally applied by cutting the stoma and then the seal, and then wrapping them around the actual button, so your feeding tube would sit in there. There's new things that are always on the market, but I think as well, prevention is always better than cure. So if we can try and figure out what's causing the hypergranulation, that's always a really good way to start. So minimising friction and securing the tubes really key as well. But Marianne, feel free to reach out with us. We're happy to send out some samples of some different things you can try and let us know how you go.
Perfect. And Marianne says, thank you for that. Well, I do think Priscilla was sending through a question, but I think she's gone quiet. Priscilla, if you want to pop yourself on chat, if you want to ask a question directly to Natalie. Otherwise, we don't have any other questions tonight for you, Nat. So it's a quiet group tonight. Is anyone going to ask a question directly to Nat? Otherwise, we'll bring this to a close. Oh, Priscilla's writing now. She may have already. There we go. How do you fund an initial appointment? There you go.
Normally it's with NDIS, Priscilla. Probably the easiest way is to send us an email and tell us a little bit about your young person and the kind of supports you need. The funding might be a little bit different if you're looking at a child who just needs a quick appointment versus needing a full assessment. But if you get in touch with us with information about your child and those sorts of needs that they have, then we can give you a call and we'll give you an estimate of fees and information about it before we arrange anything to be booked in.
Perfect. Well, I don't think we're getting any questions. I'm gonna just tell you quickly, in case you missed at the start of the session, the upcoming 2 NAPA Nights events. So that will give anyone who's still online the final chance to get a question in. But just a quick reminder that our next NAPA Nights, the next one in September, is a celebration of special with author Melanie Dimmitt. We're talking through the wonderful journey that she's been on since the release of that wonderful book that she wrote 5 years ago, and we'll be catching up with some of the original interviewees of that book to find out how they're going 5 years into their disability journey. So that one's on September 17th. And then in November, it's Mandy Hose who will lead a session on sleep and settling techniques. Mandy Hose is one half of the 2 Ps in a podcast, and she will be chatting to us about sleep and settling techniques, along with the fact that she's treating from our Melbourne clinic from October as well. So they're the 2 upcoming NAPA Nights. You can get your tickets to those NAPA Nights in the same way that you got your tickets to tonight's event, either via Eventbrite or just keep an eye on NAPA's social media, and we often put links in there to get your free tickets for these events. A big thank you to Natalie, who has given her time tonight to talk about nursing, all things nursing. If you do have any questions for Natalie, you can obviously go to her website, which you can see on screen there. It's www.cnqld.com.au, or flick them an email at admin@cnqld.com.au. But a reminder that I will send you a link to this presentation, the video presentation, tomorrow, and I'll pop all of Natalie's details in there as well. So if you do have any further questions or want to get into contact with these guys to make an appointment, please reach out. I'm going to send you on your way. Is there someone that had a question, or was that you, Nat? Was that you?
No, that was me saying thank you.
That was you.
Thanks for having us. It's always good to come along.
A big thank you for everyone. I know it's always busy, and I know that we picked 7 o'clock because we're hoping that you guys have got kids down and stuff by now, but we know that everyone's got different routines. So thank you for everyone who made the time to tune in tonight, and we look forward to seeing you at our next NAPA Nights. Thank you.
Thanks, Paul. See you guys. Have a lovely evening. Bye.
Bye.